Hello, and welcome to the Let's Talk series. My name is Desiree Hernandez, and I'm a licensed clinical social worker working at Mount SAC Student Health Services Center. Thank you for taking time to join us today. Today, we're going to be engaging in a brief discussion about eating disorders. Did you know that eating disorders is among the top 5 mental health issues on college campuses? It is important to remember that this presentation does not substitute for an official diagnosis. Please speak with a licensed professional about your personal story so that you can obtain the appropriate diagnosis. In this presentation, I will be mentioning some resources. We do not receive any compensation, nor do we endorse these resources. We are only providing you with these resources so that you could further explore on your own. So let's get started. Eating disorders are serious, life-threatening mental illnesses that can affect anyone regardless of age, race, gender identity, sexual orientation, or background. Let's take a look at some statistics. 28.8 million Americans are struggling with eating disorders. Every 52 minutes, someone dies due to an eating disorder. 26% attempt suicide. Let's take a closer look at some statistics. People ages 12 to 25 represent 95% of those with eating disorders. Anorexia is the third most chronic illness in adolescents. 91% of college women attempt to control their weight through dieting. 25% of college women binge and purge to manage their weight. Although these numbers focus on women, we know that eating disorders also impact men. However, researchers believe that the statistics for men may be misrepresented due to underreporting. Men are either not reporting or being overlooked for an eating disorder. These are the most common types of eating disorders that we will be discussing today: anorexia nervosa, bulimia nervosa, and binge eating disorder. We will be looking at the criteria that professionals use to diagnose each of these. There are many people who do not meet criteria for a specific eating disorder, but still meet criteria for an unspecified eating disorder. Again, before we move forward, it is important to note that this does not suffice for an official diagnosis. Each person has a unique situation, and it is important to speak with a licensed professional about your situation in order to acquire an accurate diagnosis. Let's talk anorexia nervosa and the DSM-5. The DSM-5 is the Diagnostic and Statistical Manual of Mental Disorders that licensed professionals use when making a diagnosis. The DSM-5 states that people with anorexia nervosa will engage in the following: restricting food intake, leading to a significantly low body weight in the context of age, sex, developmental trajectory, and physical health. Intense fear of gaining weight or becoming fat, or persistent behaviors that interfere with weight gain, even though you are at a significantly low weight. Difficulty with recognizing the seriousness of your current low body weight. Being disturbed by the appearance or shape of your body when evaluating yourself. I want to highlight here that with anorexia, a person has extreme difficulty seeing their true body weight, which leads them to restricting their food intake, which results in an unhealthy low body weight. There are major medical concerns with anorexia. Let's listen to Mount SAC's family nurse practitioner, Mindy, to hear more about the medical complications.
Hello, my name is Mindy Throop. I'm a nurse practitioner and one of the healthcare providers at Student Health Services. Thank you for joining me today. Let's jump right in. While anorexia nervosa is likely most thought of to be the most severe, medically speaking, because it has the highest propensity to end in a fatal event, All eating disorders carry significant medical risk that can and does end lives. Here we will review the medical effects of these psychiatric disorders. So let's begin with anorexia. Anorexia nervosa has the potential to affect every body system. Sometimes the medical complications are reversible, some are not, some are fatal. Each one of the complications may be linked to several others. Therefore, in a treatment setting, it will take a team of mental health specialists as well as medical specialists to care for each patient. This list that we're going to go through is by no means exhaustive. In fact, it is quite simplified, and only common complications, ones that you have likely heard of before, are noted here. Otherwise, to be honest, it can be quite overwhelming. Unfortunately, each system can be affected in a massive way to the point of failure. Beginning with medical complications of anorexia nervosa by body system, one of the most prominent is the cardiovascular system. Bradycardia and hypotension. Bradycardia means a slow heart rate, and hypotension means a low blood pressure. Sudden death caused by irregular heart rhythm, and refeeding syndrome. Refeeding syndrome is the reintroduction of nutrition too quickly, which can cause fluid and electrolyte changes in such a way that the body cannot handle, causing seizures, hypertension, arrhythmias, and possibly death. Think concentration camps. The victims were starved for months to years and had so many health problems as a result. Those that survived couldn't wait to eat, and their rescuers couldn't wait to provide food. But their bodies couldn't handle this sudden change, and no one knew, at that time anyway. Now we know. Many died after rescue because their bodies were so damaged with starvation that they couldn't handle normal. Refeeding has to be very carefully monitored so that nutrition, specifically the sugar and carbohydrates, don't upset the body in such a way that causes further shutting down of all the vital organs. Next system is dermatologic system. This is your skin and hair. Alopecia, which means hair loss. Yes, they can lose all their hair. There are many reasons for alopecia or hair loss to whatever degree. Sometimes it's just thinning and sometimes it's complete hair loss. But anorexia is one of these reasons. Lanugo hair. This lanugo hair is a very fine infant-like hair that can cover the whole body. Next system is our gastrointestinal system. Constipation leads the way. Between not eating enough for the body to absorb and also not eating enough to have waste products remaining and or facilitate motility of the gut or movement of the gut, damage to the gut because of the starvation, the process, there's an inability to produce a bowel movement is common, which leads to the next point, delayed gastric emptying. This is an inability to digest and process food in a timely manner, so everything slows way down. Dysphagia. Dysphagia means an inability to swallow productively in order to safely consume food and drink or fluids. This can result in infection if food is aspirated. So instead of being swallowed and going down the esophagus into the stomach, it is inhaled into the lungs. Our next system is the endocrine and metabolic system. This category is referring to hormonal changes which cause very important physiologic occurrences to cease or stop. So amenorrhea, for a female, this means her monthly period stops. Infertility, an inability to become pregnant. Osteoporosis, which means brittle bones. The bones aren't reproducing cells like they should. The bones become more porous. With less bone and more space, the bones break easier. This can be an indirect cause of death as somebody gets older. Hypoglycemia. This means dangerous drops in blood sugar that can be fatal in an instant. The brain needs sugar in order to function, or it stops functioning and telling the body to perform its vital functions. Hematologic system. This means the function of the blood. Pancytopenia can develop due to starvation. That means the bone marrow is unable to produce enough red and white blood cells. The neurologic system. This is your nervous system. Neurologic changes include cerebral atrophy or shrinking of the brain. The ophthalmic system. This is your eyes and vision. And the pulmonary system. aspiration pneumonia because of dysphagia. So like I said, food swallowed goes into the lungs instead of the stomach and can sit there and cause an infection. Respiratory failure. At this point, things are shutting down. There's been so much damage done to the body, it is difficult to save a person. All right, next stop, bulimia.
Now let's talk bulimia nervosa and the DSM-5. The DSM-5 states that people who are struggling with bulimia will engage in the following: recurrent episodes of binge eating. Binge eating is described as eating in a short period of time, usually within any 2-hour period, an amount of food that is definitely larger than what most individuals would eat in a similar period of time under similar circumstances. A sense of lack of control over eating during the episode. Engaging in behaviors to compensate for binge eating to prevent weight gain, such as self-induced vomiting, misuse of laxatives, diuretics or other medications, fasting, or excessive exercise. Binge eating and compensating behavior both occur on average at least once a week for 3 months. Bulimia is characterized by overeating and then engage in behaviors to counter that weight gain. So it's important to note here that with bulimia, a person can actually have an average weight, a normal weight, so it may be difficult to tell if a person is struggling with bulimia. Bulimia also comes with its own set of medical concerns. Let's hear about some of the medical complications that can occur.
Now let's visit the medical complications of bulimia. While the list is not quite as long as the starvation-induced effects that anorexia imposes on virtually every body system, bulimia has its own unique characteristics and traumas on the body. Self-induced vomiting, the use of laxatives, excessive exercise, and restricted oral intake can cause both short-term and long-term damage. Ongoing vomiting is immediate, but there's also repeated trauma to the oropharynx, which is the throat and mouth, as well as the stomach. The use of laxatives results in electrolyte imbalance, which increases the risk of arrhythmias. Damage to the heart can lead to congestive heart failure, more dangerous arrhythmias or irregular rhythms, and sudden cardiac death. I'm going to briefly list complications of bulimia. Stomach rupture, heart problems due to the loss of minerals and electrolytes such as potassium and sodium. Imbalances in these electrolytes can cause these irregular heart rhythms and death. Dental problems, the acid in the emesis or vomit wears down the outer layer of your teeth. An inflamed esophagus, again, because of the acid that is forced back upwards during vomiting, there is inflammation and erosion. Swollen glands in the cheeks, irregular menstrual periods, kidney problems, diminished sex drive or libido. Addictions, substance abuse, and/or compulsive behavior tend to accompany bulimia. Depression, anxiety, obsessive compulsive disorder, and other mental health problems, which are added physical stressors to the heart, increasing the risk of cardiac disease, and suicidal behavior. Clearly, bulimia has its share of serious complications.
Now let's talk binge eating disorder and the DSM-5. The DSM-5 lists the following as criteria for binge eating disorder. Binge eating occurs on average at least once a week for 3 months. A person engages recurrent episodes of binge eating, eating in a short period of time, an amount of food that is larger than what most people would eat in a similar period of time. Feeling like you cannot stop eating or control how much you are eating. Binge eating episodes are associated with 3 or more of the following: eating quickly, faster than normal, eating until feeling uncomfortably full, eating large amounts of food when not feeling physically hungry, eating alone because feeling embarrassed by how much you are eating, feeling disgusted with oneself, depressed, or very guilty afterward. Binge eating does not involve compensatory behaviors. So binge eating is similar to bulimia in that a person still engages in overeating behaviors, binging. However, this person does not engage in behaviors to try to counter the weight gain. As mentioned, a person who binges feels extreme embarrassment and guilt over binging. They often have difficulty eating in public and feel completely out of control when they are eating. Binge eating typically leads to being overweight or obese. So let's listen to some of the medical complications that can occur with binge eating.
Lastly, we will touch on binge eating disorder. Because binge eating disorder is a little less common, I'm not going to go into as much detail and only highlight some of the main points. Binge eating disorder is strongly associated with severe obesity. It carries an elevated risk of medical comorbidities. Many of these associations may be due to obesity, but not necessarily. Diabetes, hypertension, and pain conditions are associated with binge eating disorder after controlling for other diagnoses like obesity. This means while obesity and binge eating disorder may occur simultaneously and have overlapping conditions that are not dependent on one another to produce said conditions, individuals suffering from binge eating are likely to develop diabetes, hypertension, and pain issues, regardless of whether they are obese. Metabolic syndrome is observed in approximately 50% of people seeking treatment with binge eating disorder. Metabolic syndrome is the term used to describe the occurrence of these issues collectively, but together they further exacerbate each other and cause further damage. Diabetes mellitus, hypertension, obesity, and dyslipidemia or high cholesterol together are coined metabolic syndrome. Other complications include sleep disorders, asthma, gastrointestinal symptoms, menstrual dysfunction like irregular periods and amenorrhea, pregnancy complications, intracranial hypertension, that means increased pressure in the brain, and polycystic ovarian syndrome. This means this tends to include a hormonal change that include hair growth. It can cause increased hair growth on the face and body, hyperglycemia, which means increased blood sugar, increased weight and difficulty in losing that weight, changes to the menses and difficulty getting pregnant and or infertility. Realizing that collectively over the course of these 3 eating disorders we have discussed, this is a lot of information, and we cut out we only touched on the very simplified view. What I hope you can take away is that while these diseases may be primarily psychological in origin and oftentimes in treatment, they have very serious medical comorbidities or physical consequences that can be permanent, devastating, and fatal. If you or someone you know is exhibiting signs or symptoms, please reach out for help. You are not alone, and there is help both psychologically and medically. Your life and vitality is at stake. Thank you.
Now let's talk risk factors. Now, there are no direct causes to having an eating disorder. And risk factors do not automatically mean that you will have an eating disorder or any other mental illness. But research has shown that people with eating disorders have any combination of these risk factors present. Biological risk factors include having a close relative with an eating disorder, having a close relative with any other mental health disorder. A history of dieting has shown increased chances of developing binge eating disorder. Although research shows that females have a higher rate of developing eating disorders, men also develop eating disorders and may underreport. Psychological risk factors include having low self-esteem, poor body image, a history of anxiety disorder, having other mental health disorders, having perfectionism tendencies, and trauma histories. Social risk factors include weight stigma, this idea of ideal body type, history of being bullied or teased. This doesn't just take place in schools, but family culture and family members can be classified as bullies too. And limited social networks, or being isolated or have limited social interactions, can lead to having an eating disorder. So now we're going to shift and take a look at treatment options for eating disorders. Our Assistant Director of Student Health Services, Dr. Seth Myers, highlighted important information regarding treatment options. A multidisciplinary team should be used to treat an individual with an eating disorder. Medical professional, mental health professional, a dietitian, and even a case manager in the most severe cases. Because eating disorders are complex and encompass both medical and psychological problems, it is important to have a health professional from different disciplines. An individual with an eating disorder may be treated in a clinic, in a day treatment program or day hospital, or in an inpatient hospital that has a psychiatric unit. The treatment setting depends on your individual needs and will be discussed with you or your loved one. Length of treatment depends on the individual's specific needs and severity of their illnesses. Treatment can range from a couple of weeks to a couple of years. One of the most pressing questions is how long recovery takes, but it's important to avoid focusing on the length of time, but focusing on grasping and creating long-lasting changes to better yourself. Dr. Myers also highlights some tips when seeking mental health treatment for an eating disorder. Eating disorders should not be treated by just any mental health professional, even if the professional is licensed. Eating disorders involve a complex set of mental and medical symptoms that must be treated by a mental health professional who has specialized experience in this area. The average mental health professional has not received extensive training in this area and often has not treated a high number of individuals with eating disorders. If a person has a diagnosable eating disorder, that individual should be treated by someone who has a history of treating many patients with that specific eating disorder. Your therapist should be a licensed professional who specializes in treating eating disorders and who has had experience and specific training to work with you and your situation. Now let's talk mental health therapy and eating disorders. There are several approaches to the mental health treatment of eating disorders. And like already mentioned, each person has a unique situation, which will result in a specialized treatment plan for the individual needs. Listed here are a couple of common mental health treatment strategies. The first is cognitive behavioral therapy. A CBT approach to eating disorder treatment works to create change in the way a person thinks about weight, their body, and food. When healthier, more effective beliefs are built and maintained, eating disorder behaviors should reduce. The second is family therapy, typically used with children and adolescents. However, research has shown that family involvement in treatment can improve the outcomes of the patient. The patient and family work with a therapist to focus on establishing healthy eating and exercise habits. Research shows that family involvement enables the patient to make significant progress. Now I'm going to show you some resources that you can utilize as a starting point to maybe find treatment or explore further information about the different eating disorders. The first resource I'd like to share with you is the National Eating Disorder Association, NEDA. There you can learn more about eating disorders. You can get support and resources. They have an online screening tool, and they also have a helpline or chat line. Here's the website there, nationaleatingdisorders.org, and you can explore their hours of operation. The second resource I'd like to share with you is the National Association of Anorexia and Associated Disorders, ANAD. There you can get informed. They have information there, webinars, blogs. They have book recommendations. You also can explore getting help through them. They have a helpline, and they also have some support groups. The website there is anad.org. And the last local resource I'd like to leave you with is the LAC-DMH. So that's LA County Department of Mental Health. This is their helpline, and it's 800 number, toll-free, 24/7 hotline. You can get direct resources for treatment. And there's the DMH LA County website listed there as well. Here are some emergency services as well. The first is the Need Help. Text COURAGE to 741-741 hotline. It is a crisis text line. It's free 24/7 mental health support via text message. When you text, you will get a licensed professional to help you through your crisis. There's also the National Suicide Prevention Lifeline, 1-800-273-TALK, 8255. And it is free to call as well. It's totally confidential, available 24/7 as well, and you speak with a trained professional. And then in the event of any life-threatening emergencies, please call 911. I know I mentioned through this presentation that eating disorders do cause medical problems, and so there are some medical emergencies that can be related to eating disorders, so please call 911 if this situation applies to you. I want to leave you with real-life accounts from real people who have lived with or are living with an eating disorder.
I developed an eating disorder at the age of 14. It was anorexia.
I was around 12 or 13. I was 11, 12.
My sophomore year of college.
7th grade.
It came out of the context of my parents splitting up. There was just, a lot of stress.
Pressures from the media.
I would compare my body to the bodies of professional soccer players, to professional models, and look and say, oh, my abs don't look like that. That's something wrong with me.
At this age, I was already reading fashion magazines, and so if Cosmo said, don't eat bread, I was eating rice crackers instead of bread. I guess that's exactly the point when the eating disorder might have started.
And also the stress of just doing well in school. A way that I could control all of those outside things was by controlling my body. Essentially, I would heavily restrict and avoid eating at all costs. So I wouldn't really eat at family meals, lunches I would throw away.
I began to binge very regularly, and binging slowly took over more and more of my life. I think in the very early stages, I didn't really have any vocabulary for it. I didn't know what it was. I didn't know why I was doing it. The thought of eating in front of other people was so shameful.
It was all restricting. It was cutting back on meals, eating only low-fat and low-calorie meals, and then skipping meals entirely.
I lost a lot of weight because I wasn't eating, because I would just be like, I don't have time to think about that stuff. I'd rather just do work. The coffee allows me to have energy to keep on working and also suppresses my hunger.
I had a therapy session with my therapist, and she traced my body, and then I got off of it and looked at the size of it. And she was like, do you see how small that is? Like, not normal. And I remember thinking like, no, that seems like completely fine to me. Like, that seems like a fine, normal body shape.
I felt ashamed, and so I would literally try to hide it by, I'd have a plate of food, and instead of eating part of it, I would shove some of it into a napkin and throw that away.
I don't think any portion of food felt comfortable to me, unless it was like a cracker or two.
Friends in high school would see me not eating my lunch, and then I would just say I had a large breakfast, but to do that days and days and days in a row, I'm falling asleep in class because I'm so exhausted because I don't actually give my body any nourishment.
I think the low point for me was, when my eating disorder progressed from not only including restrictive behaviors, but including bulimic behaviors like binging and purging.
At the end, when I was more bulimic, I would spend every hour of every day thinking about when my next binge purge episode was going to be.
I began binging very heavily and becoming very secretive. Binging in the dark, in the bedroom, making sure all the doors were locked. Really, it's always been about anxiety in my personal experience.
When I'm feeling most stressed about something, I become very, very precise about what I eat, because it's almost like I need to somehow take control of my body when I feel like everything else is falling apart.
My mind would go blank and I would just eat whatever I could find, not even things I enjoyed. And so after I would purge and then sit on the bathroom floor and just think about how I had no control over the last 30 minutes of what just happened, I didn't know how to stop it.
I think really it's always been about anxiety. With binging, there was in those moments a little bit of relief from that, and it's really the only time I'd ever felt any relief. The problem, of course, with eating disorders is you get an immediate sense of shame. It felt like a punishment, and that I deserved to feel the way I felt after a binge, which was, terrible.
It was pretty scary when I was in a doctor's office at the end of my freshman year and was hearing about how I could have a heart attack because I was just putting that much stress on my heart.
When I started treatment, I was still resisting a little bit, so I really didn't like talking to my medical providers at all about anything, even though I'm sure they were perfectly qualified.
When I initially sought treatment, the biggest obstacles I faced were finding providers that were able to focus on what I needed as a male in the eating disorder community.
My therapist basically told me that I needed to get more intensive help or I was going to die. I went for an intake at a treatment program and they confirmed that I needed a very higher level of care. The doctors who I interacted with during my treatment and recovery never quite seemed to understand what I was saying or why I was there. There were a few doctors who were ignorant to the point of it being kind of damaging.
I think with any mental health disorder, I think being sensitive to the situation is really important. Creating a rhetoric where the patient feels safe and comfortable.
I think when somebody in a medical profession doesn't know what to do with the knowledge that their patient has an eating disorder, it adds to the feeling of isolation and shame, because you think to yourself, well, this is somebody who went to medical school and even they don't really understand what's happening with me.
Some of the more ignorant comments would bring back that old fear that what I was feeling and thinking wasn't valid, that I was crazy, that I was exaggerating or making this whole thing up.
I've wanted to get to know myself and wanted to just take a second and be like, why do I feel like eating that? And what is it that I actually feel like eating?
There's a lot of debate about whether one can recover completely and be recovered, or you're just perpetually recovering and always, have to be cautious about the things you see and what you eat. I truly believe that it's possible to recover, to have it no longer be an option no matter what life throws at you, to, that no matter what, you will not resort to an eating disorder to deal with your problems. I think it's possible to recover completely. My name is Joanna K. Mercuri, and I'm recovering from an eating disorder.
My name is Justin Shmoon, and I had an eating disorder.
My name is Shayna Gonsalves, and I think I might still be experiencing an eating disorder.
I'm Pooja Patel, and I had an eating disorder.
My name is Stacy, and I had an eating disorder.
Thank you for your time, and we hope that you were able to learn and grow with us today. We hope to see you back for more of the Let's Talk series. Have a great day.